inviting me to to share what I know about post-op cardiac patients with the group. This is actually the second time, so I'm really happy to get invited again. So today we're going to talk about the post-operative care of a neonate after single ventricle palliative surgery. Hold on. As you know, the care of a postoperative cardiac patient is so broad, and it encompasses both two ventricle and single ventricle palliative repair. And it's not just going to focus on hemodynamics. So for purposes of this lecture, I'm just going to focus on single ventricle palliative repair, and I'm going to talk about what that means later on, that you're probably familiar with it. I'm going to focus on hemodynamic management and the goals of management. At the end of the lecture, I'm going to give you an overview of how we sort of do things at Yale. So there's significant variability in the care of a post-operative patient, like after Norwood. This study was conducted by Yale University in 2007, and pretty much the way they did it is they asked big centers in the U.S. like how they would manage a patient after Norwood. And you can just see that in the next two slides, I'm going to show you 4 graphs that there's significant variability in how patients are managed in the U.S. So, for example, the figure on the left shows you the use of elective delayed sternal closure, meaning having an open chest right after surgery. Half of the respondents would say that pretty much always these patients would come up to the ICU with an open chest, but the rest of the group is pretty much essentially never to frequently. Another example, the amount of or the type of IV infusion that they receive after is again very broad, from milrinone, where pretty much everyone essentially uses it, to phenoxybenzamine, which pretty much everyone doesn't use it. And then you have different gradations in between with the use of dopamine, epi, and then nifride. The same as for neuromuscular blockers and narcotic analgesia. Some centers would essentially always place them on continuous blockers, while others would essentially never do it. The same as for narcotic analgesia, some would essentially use it always for this patient, and some would use intermittent dosing. And then lastly, which I'm going to talk about later on, is the use of NIRS, or near-infrared spectroscopy. There's a very wide variation on whether they get used in the ICU or not. So the goals of management of post-op cardiac patient, which I'm going to use as the outline for this presentation, are as follows. The number one thing that needs to be done is to balance the demand and supply. 2 is to maintain and actually improve cardiac inotropy. 3 is balancing QP and QS, meaning pulmonary blood flow and systemic blood flow. And the 4th I wrote here as maintenance of adequate blood pressure and arterial oxygen sat. But as I'm going to emphasize later, the 4th goal of management is really irrelevant if you've maximized the top 3. So just a brief review of single ventricle physiology. When we say single ventricle physiology, that means there's only one functioning ventricle, and there's a mixing of both the systemic and pulmonary venous return. And then the cardiac output that comes from the functioning ventricle is partitioned between the pulmonary blood flow and the systemic blood flow. The amount of blood to the lungs, to the rest of the body, is determined by the amount of anatomic obstruction in each of the outflow tracts and the vascular resistance to flow. The most important anatomic issue in a single ventricle physiology is the obstruction to and from the systemic ventricle and lungs. As you can imagine, the amount of blood going back to the heart is going to be determined whether the inflow is obstructed either from the lungs or from the rest of the body, and then the outflow is going to be the same. The amount going out of the heart is dependent on the obstruction from the outflow tract. This table lists some of the common diagnoses associated with single ventricle physiology in the newborn. As noted in the table, not all of these are single ventricle lesions, and the way we differentiate it is some patients pre-op would be single ventricle in physiology. So an example is critical aortic stenosis or critical coarctation of the aorta. However, because the ventricles are inherently formed, they can actually end up with a biventricular repair after. So all of these lesions are associated with single ventricle physiology prior to the OR, but only some of these are going to end up with a single ventricle physiology after the OR. And the classic example is the hypoplastic left heart syndrome, where the left ventricle is well developed such that it cannot support systemic circulation after. So this is the classic single ventricle of the hypoplastic left heart. So you have an enlarged right ventricle because the left ventricle never developed. It has a huge pulmonary trunk because it has to supply both the pulmonary and the systemic circulation. And then you have a diminutive ascending aorta because the left ventricle never developed, so there's not enough blood flow to the aorta. That's why it also never developed. And then in order to connect the two circulations, the systemic and the pulmonary, then you have a huge patent arteriosus, which is pretty much life-saving. So these patients undergo 3 stages of repair, and we call them palliative surgery because they never really end up with a two-ventricle physiology. So for semantics-wise, a patient is fully repaired from a surgical point of view if they end up with a two-ventricle physiology after. But single hypoplastic left heart patients never really cannot have two-ventricle repair, so we only have the palliative surgery. So the goal for the first stage of surgery, which is either going to be a Norwood with a modified DT shunt or pulmonary artery banding or a Sano shunt, is to establish an unobstructed pulmonary and systemic venous return. So remember, the saturation and the perfusion of these patients will depend greatly on how much blood flow goes back to the lungs. So it goes back to the heart. So you want to make sure that they're not obstructed. And then the other thing is you want to make sure that there's no obstruction in the systemic outflow because you want to maximize the oxygen delivery to this patient. For the pulmonary blood flow, you actually want to make sure that it's just enough to maintain oxygen delivery. You don't want the lungs flooded because it's going to increase your pulmonary artery pressure. You can have signs of pulmonary vascular hypertension, which is going to be a huge problem as you move on to the second and the third stages of surgery. And again, the way we do it is a Norwood with a modified BT shunt or pulmonary artery banding or a Sano shunt. What does that mean? So this is the final appearance of a completed Norwood. So if you remember, a Norwood is a reconstruction of the diminutive ascending aorta. Because the right ventricle is going to be the systemic ventricle, then you use that to connect it to the ascending aorta. So you use part of the pulmonary artery as the trunk of the neo-aorta, and then you patch it to make the aorta as wide as possible. And then because you have to take off the ductus arteriosus, then you need to have a way of supplying the pulmonary artery with blood, which obviously goes to the lungs. And there are 2 ways right now of doing that. One is either through Gore-Tex shunt, which is a modified BT shunt connecting your subclavian to your pulmonary artery, or the other one that can also be done is an RV2PA conduit, which is what we call a Sano shunt. There are pros and cons of doing each of this surgery. There's been a head-to-head comparison between the two, but it seems like the Sano shunt is easier to manage post-operatively, but the overall outcome in terms of repair, I just don't know what happened. In terms of the repair, it's really pretty much the same. What about the second and third stages of surgery? So the second stage is what we call bidirectional cavopulmonary anastomosis or a Glenn shunt, in which what we do is to connect the SVC, or superior vena cava, to the pulmonary artery. And while commonly we use a Glenn shunt for that, some people would still do a hemifontaine anastomosis. And then lastly, the third stage is the creation of total cavopulmonary anastomosis, where both the SVC and the IVC are connected to the pulmonary artery, and that's what we call the fontaine anastomosis. So this is just a diagram of the three different stages of palliative repair in these patients with a single ventricle. So I mentioned the Norwood with the modified VT shunt and the Sano. So in the Norwood, so you have both SVC and IVC going back to the heart, and then blood goes out to the heart, and then you have a connection from the subclavian to the lungs, which is your VT shunt, and then through the lungs goes back to the heart with the pulmonary vein. And then the rest of the blood that goes to the body, perfuses the body, and it goes back to the SVC, IVC, and then back to the heart. In contrast to the Sano shunt, well, both SVC and IVC drain to the heart. The connection is a direct connection from the heart towards the lungs through the Sano shunt, and then you have another one that goes to the rest of the body. With the bidirectional cavopulmonary anastomosis, or your Glenn shunt, so what happens is your SVC gets directed to the pulmonary artery, and then that blood goes to the lungs. The amount of blood going to the lungs goes back to the heart, but the IVC is still directly connected to the heart. So these patients are still desaturated because you still have mixing of desaturated blood or deoxygenated blood from the IVC and the oxygenated blood from the lungs. And that mixed oxygenated blood goes to the rest of the body and then goes back to the SVC, IVC, and then back to the lungs or even the heart. And then lastly, for the fontaine, what happens is you divert both SVC and IVC to the lungs, so all the blood that gets drained from the body becomes oxygenated, and that oxygenated blood goes to the heart. So the rest of the body gets pretty much nearly completely oxygenated blood. The only thing that's deoxygenated is the one that's coming from the coronary sinuses. So patients with a fontaine usually sat in the low 90s, but definitely much better than the prior stages. So there's a new thing that people in the US are actually trying, and I don't know whether this is something that you guys are doing in India. And this is what you call a first stage hybrid surgery. So the bulk of mortality in hypoplastic left heart occurs in what we call the interstage, meaning after the Norwood and before the Glenn shunt. So that's one of the issues. And then the other issue is it's really technically difficult to do either the Sano or the Norwood. And the very good surgeons achieve very high survival rate, but it's relatively hard to duplicate. So what some people are actually doing are, rather than going for the Norwood during the child's neonatal period, what we're doing is to keep the PDA patent by doing ductal stenting, and then to minimize so that's actually going to achieve perfusion to the rest of the body, and then to minimize the amount of blood flow going to the lungs, to minimize pulmonary hypertension, people do PA banding, and then during around 2 to 3 months of age, where other kids would have their Glenn shunt, that's when people would do the Norwood and then a Glenn shunt both at the same time. So they would put the homograph, take the PDA out, and then do the Glenn shunt connecting the SVC to the pulmonary artery. There's still very little experience with the use of the hybrid surgery, and it really takes a lot of financial investment for you to do this, because you need to have a suite where it's both interventional and operative suite. So we at Yale personally don't do it, but I know some other centers have been doing it commonly. So going back to the major focus for this presentation, so I like this statement from Schwartz, and because it really emphasizes on how we should manage patients after the Norwood. And you can just read through it. The goal of management in single ventricle physiology is to ensure adequate oxygen delivery and not to maximize oxygen saturation. And I think we're always fooled that we manage our patients based on the saturation. But as I'm going to show you later, there's a lot of pitfalls in doing that, and it's really the oxygen delivery that's what you want. You want to make sure that the body is adequately perfused with enough oxygen. And the way to optimize their oxygen delivery is to maintain cardiac inotropy while at the same time balancing your pulmonary blood flow and then systemic blood flow. And in fact, maintaining adequate blood pressure and arterial saturation is the least of your concern in this patient. And as I mentioned earlier, if you actually do a good job in doing numbers 1, 2, and 3, number 4 sort of just follows. So how do you balance demand and supply? To me, every time I talk about the human body, it's pretty much the law of economics. You have demand on one side and then supply on the other hand. When we talk about oxygen economics, your demand is your oxygen consumption, and then your supply is oxygen delivery. And the body, as much as possible, maintains a balance between the two. In fact, the body has 4 times more oxygen delivery than oxygen consumption. So you have a lot of buffer before things go bad. In fact, this is a classic oxygen consumption versus delivery graph. So as I mentioned earlier, we have more than enough oxygen delivery than what the body can consume. So at this point onward, the amount of delivery is not dependent, and the amount of consumption is not dependent on the amount of delivery that the body can do. And so that's why it's called oxygen delivery independent part of the curve. However, if you reach a particular critical threshold, then now your oxygen consumption is going to be dependent on your oxygen delivery. That's when the body starts going to anaerobic metabolism, and that's where you get into a lot of problems. So you should be able to keep your patients in this part of the curve so that you don't have to worry about this one. So what are the so what you want to do up front is to minimize oxygen consumption. And this table shows you the different factors that may increase metabolic requirements in a post-cardiac patient. So you have catecholamines, whether that's endogenous or exogenous. You have systemic inflammatory response. You have fever. You have consciousness, which, as you know, the brain consumes the most amount of oxygen. And then you have pain, anxiety. They have spontaneous breathing, and then enteral nutrition. So what do we do for this patient? We really can't do anything about the endogenous catecholamines, but we can try to minimize the exogenous amount of catecholamines that we give. We try to minimize systemic inflammatory response by giving steroids during the patient's pump run. We control fever as much as possible, and sometimes keeping them in the relatively hypothermic range, meaning like around 36 degrees Celsius. We keep them very sedated, and sometimes we actually just keep them paralyzed just to minimize the amount of oxygen consumption. And that's going to take care of your pain, well, obviously analgesia, pain, anxiety, consciousness, and then, as I said, we minimize the work of breathing. And usually in the first post-op night, we put them on NPO, not necessarily to minimize the oxygen consumption, but because we're really not sure what the gut is doing at that point. So this is a curve that I want you guys to sort of like know by heart. And what this what this figure is showing you is, with the systemic oxygen delivery on the y-axis, and then QPQS on the x-axis. So what this figure is telling you that if you maximize your oxygen delivery, your QPQ is sort of like irrelevant. However, as your cardiac output or oxygen delivery decreases, then QPQS becomes more important. Again, we're always taught to try to maintain your QPQS as close to 1 as possible, but as this figure is showing you, that's less of a consideration as long as you maximize your oxygen delivery. Again, this is the oxygen deficit that I was talking to you earlier, where your VO2 and CO2 are proportional to each other. So that's when your QPQS becomes very important. But again, the corollary is if you maximize your oxygen delivery, then you should be in a good state, regardless of what your QPQS is. So how do you maximize oxygen delivery? This is sort of the classic physiological diagram. So your oxygen delivery is a function of your cardiac output and your arterial oxygen content. Your arterial oxygen content is dependent on hemoglobin content and affinity. Your cardiac output is of your stroke volume and heart rate, and then your stroke volume is affected by preload, myocardial contractility, and afterload. I'm going to talk to you about each of these in the subsequent slides. So this is a formula for arterial oxygen content. Remember that oxygen is either bound to hemoglobin, which is this part of the formula, and or dissolved in blood, which is this part of the formula. And again, as you know, the bulk of oxygen carried in the body is bound to your hemoglobin. Knowing that, the best way to increase your arterial oxygen content is to actually increase your hemoglobin. So just looking at this graph, PO2 x-axis, arterial oxygen content in the y-axis. For any particular PO2, your arterial oxygen content is always going to be higher with a higher hemoglobin. In fact, if you graph oxygen transport with hematocrit, the peak oxygen transport or oxygen delivery actually occurs with a crit of 35 to 50%. Below 35%, then you don't have enough oxygen carrying capacity. Higher than 50%, you run the risk of increasing systemic and pulmonary vascular resistance because of the increased viscosity of the blood. So we tend to keep it like 35 to 50%. What about cardiac output? The phenomenon of low cardiac output syndrome is very well documented. Gil Vernovsky first pointed this out in patients who were undergoing arterial switch. So what they've shown is right before bypass, you have an ejection fraction of around like close to 80%. But pretty much within 6 to 12 hours after bypass, it dips down to around 50%. So there's a significant decrease in your cardiac output. And then this sort of just increases after the 6 to 12 hours after bypass. So again, so this was first described in arterial switch patients, but we know clinically that this happens pretty much in all types of postoperative cardiac patients. And in someone with a Norwood, where you're relying on the right ventricle for systemic circulation, this may become a major issue, such that when we're on call for post-cardiac patients, we keep an eye on this time period, the 6 to 12 hours after bypass, because we know that if something's going to go wrong, it's going to be around this time period. So the problem with the single ventricle physiology, as I mentioned earlier, is that your cardiac output goes into parallel circulation. So so after it leaves the heart, then blood either goes to the pulmonary circulation or the systemic circulation, such that in the presence of a low cardiac output state in a single ventricle physiology, it's going to present with low systemic circulation and then signs of low perfusion to the lungs. So the classic low cardiac output presentation that these types of patients are desaturated patients with poor urine output, poor capillary refill, high ventricular filling pressure, or metabolic acidosis. And as you know, this is the acidosis is because these patients go into anaerobic metabolism. So how do we pick this up? So aside from those signs and symptoms that I've mentioned, We use additional technology to try to figure out what's going on. So you can get an echo just to see what your cardiac function looks like. We do serial lactate levels, and again, it's a measure of anaerobic metabolism. We use bicarb and base deficit. So we tend to keep our base deficit within ±4 or sometimes even ±2. And if it goes more negative than that, then we're just concerned that the body's not getting enough oxygen and they're in a low cardiac output state. Venous oximetry as a surrogate for cardiac output, and unfortunately, in a single ventricle repaired patient, there's the only surrogate for cardiac output that we can use is an SVC line, which we don't always get. So what people tend to be using a lot more is the cerebral near infrared cerebral oxygenation or NIRS. So what does that look like? So the picture on the left shows you a baby with a NIRS. So this is actually the NIRS sensor. Forgive me if you guys are familiar with this. I don't know what you guys have in India. So just so everyone is familiar with it. So these are the monitors which actually corresponds to this one. It emits a light source. It's the same principle as what you do with the pulse oximeter. It emits a light source at different wavelengths, and then it gets picked up on the lateral sensors. And then using that through some algorithm, the machine spews out what the cerebral oxygenation looks like. And again, the beauty of NIRS is to give you a surrogate for SVC saturation, which is again a surrogate for cardiac output. This is one of the better conducted studies comparing SVC saturation with near-infrared spectroscopy, and there seems to be a very good correlation between the two, such that if your SVC sat is going up, meaning you have improved cardiac output, then your NIRS number also goes up. So how do you maintain cardiac inotropy? Because this is the second goal of your management. And so again, it's just a matter of cardiac output. So what affects cardiac output? So you have your inotropy or your myocardial contractility, you have your preload, and then you have your afterload. So ways to improve your myocardial contractility, we want to make sure that the patient's serum calcium is normal. As you may know, neonates are very dependent on extracellular calcium because they don't have enough sarcoplasmic reticulum to hold calcium within the cells. So if these patients are hypocalcemic, you can just see that the cardiac output is very low, and sometimes it's just a matter of replacing that calcium. The choice of inotropes is very important. I have a couple of slides to discuss this. Cardiopulmonary interaction, meaning the way we ventilate our patient, actually affects cardiac output. And this was the topic of my presentation the last time I did it to your group. Sometimes we bring up these patients with an open chest, and that leads to sternal closure. And sort of the theory behind that is if you close the chest, then that's added stress to the heart. It prevents it from contracting well. So if our surgeons feel that cardiac output is borderline, then they would bring the kid up to our unit with an open chest and then plan to close it a couple of days after. And then if all things fail, then we end up with mechanical support. In adults, they do a lot of ventricular assist device, but for neonates, it's still ECMO. That's our sort of like go-to guy in terms of mechanical support. But never forget that preload is actually very important. You need to maintain adequacy of your preload. So typically, I keep my preload with a CVP of around 8 to 10. Usually, once you're going beyond 10, that is probably a sign of poor myocardial contractility. More fluid is not going to solve that problem. In fact, you're probably going to worsen it. And then very importantly is you need to maintain sinus rhythm. The atrial kick contributes to at least 25% of the total cardiac output. And in a single ventricle, a post-Norwood patient, this becomes very important because their myocardial contractility may be marginal at best. And then in terms of afterload, we actually minimize vasopressor because we don't want to increase the load on the ventricle. So the diagram on the left, it is a cartoon of how eventually myocardial contraction happens. And again, the most important thing is your end messenger is actually calcium. And as I mentioned, if your calcium is low, then you're going to have problems with myocardial contractility. But other things that are positive inotropes, you have adrenergic agonists, you have cardiac glycosides, mentioned about calcium. Sodium is oftentimes mentioned, but in reality, I don't really think it's a big issue for post-cardiacs. And then increasing your heart rate, assuming that's sinus. In the immediate post-op period, we don't use cardiac glycosides. This is more in the sort of like the chronic stage. And you want to avoid as much as possible those that are going to give you a negative inotropic effect. So what's the goal in improving your with your inotropic support? So what you actually want to do is to improve your cardiac output with the lowest acceptable systemic vascular resistance. So if you remember, blood pressure is the product of cardiac output and systemic vascular resistance. That means if you want to increase your blood pressure, you can increase your cardiac output or increase your SVR. I'm telling you right now that we're oftentimes fooled by this because people want to improve your blood pressure, and sometimes that happens at the expense of cardiac output. Some of the pressors that we give increase SVR, so you can see an increase in the blood pressure, but that's not what you want. What you want to do is to increase your cardiac output because what you want is perfusion. That's why we want to make sure that we only maintain the, we want to decrease your systemic vascular resistance as much as we can. If you have improved cardiac output as a cause of your increase in your blood pressure, then what you're giving is improving your stroke volume. And again, as I mentioned in a single ventricle physiology, that would equate to an increase in your systemic and your pulmonary perfusion. And again, this results in a marked increase in your systemic oxygen delivery. So it's a good idea to review the cyclic AMP pathway because this gives us an idea of how the different catecholamines and some of our inotropes work. So you have beta receptors in the cellular membrane, and that's where your catecholamines work on. So you have your epi-dope, your dopamine. That affects your guanylate cyclase, adenylate cyclase system. So that converts ATP to cyclic AMP. An increase in cyclic AMP results in inotropy in the heart and vasodilation in the vasculature. Cyclic AMP gets degraded by phosphodiesterase 3 to AMP. So if you actually block PDE3, then you have an increase in your cyclic AMP, which is pretty much what your milrinone does. So what agents do we typically use in the ICU? So we have milrinone, epinephrine, and then dopamine. Milrinone is the ideal agent because, as you've seen in the previous slide, that actually increases your cyclic AMP. That leads to an increased inotropy in the heart and a decrease in vasodilation or a decrease in SVR in your peripheral circulation. We have, and I'm going to show a couple of slides that is real. Sort of our second choice is low dose epinephrine, so that's a dose of 0.05 to 0.1 mics per kilo per minute, and that gives you a greater inotropic support while decreasing SVR, and that works through your catecholamine receptors, so beta 1 and beta 2 receptors. And then the least useful is actually dopamine. You have modest inotropic support, however, it does not decrease your SVR and at higher doses actually even increases your SVR. So overall, this translates to a worse oxygen delivery. So we try not to do that. So this figure comes from Anthony Chang, and it gives you the pharmacodynamic effect of milrinone. So this is baseline after loading and infusion. The cardiac index is on the y-axis. So what this shows is that there's a significant increase in your cardiac index if you load these patients with milrinone, and you keep that cardiac index high by placing these patients on an infusion. This has been proven in this physiologic effect has been proven in a large randomized controlled trial where they compared placebo, meaning no milrinone, low dose milrinone, meaning 0.25 mics per kilo per minute, and then high dose, which is 0.75 mics per kilo per minute. The primary outcome measure for this study is the low cardiac output syndrome or death. And there's and what this table shows is that what this figure shows is that there's a significant decrease in the incidence of low cardiac output syndrome and death in the presence of high dose milrinone. There's a trend with low dose, but definitely an improvement with high dose milrinone. So this has been standard practice in the U.S. Anyone who goes on bypass to minimize the risk of low cardiac output syndrome, we put them on milrinone right after bypass before coming to the ICU. What about the effect of epi and dopa on oxygen delivery? Just focus on the this part of the slide. So what they did is to give this patient, these are on 100% FiO2, so from baseline, this is oxygen delivery on the y-axis. So with epinephrine, if you start them on either 0.05 or 0.1 mics per kilo per minute, there's a significant improvement in the oxygen delivery, which is almost twice as what it was prior to baseline. However, if you do the same experiment in patients with dopamine at doses of 5 and 15, there's no significant improvement in oxygen delivery. So this argues for the use of epinephrine over dopamine in patients in order to improve their oxygen delivery. So the third goal is to balance the QPQS or pulmonary and systemic blood flow. So the whole concept of QPQS comes from the Fick equation, where it says that the oxygen consumption is a product of your pulmonary blood flow and then the arterial venous oxygen difference. So I mean, this slide just gives you the derivation of the QPQS. So it's just a matter of putting QP over QS. So you end up with this equation. Since saturation accounts for the majority of your arterial oxygen content, you can actually substitute oxygen saturation instead of arterial oxygen content. And you can actually simplify that because the arterial oxygen, the systemic difference between the arterial and venous oxygen is usually around 25%. And typically, your pulmonary veins have a SAT of 95%. So this equation of QPQS it's a very trimmed down formula, and I'm going to show you later that this becomes a problem when you're dealing with patients with post-op Norwood. So using this formula, you can have an idea of what the QPQS is just based on the patient's arterial oxygenation. So a 75% arterial oxygenation gives you like a QPQS of close to 1, and 85% is something like close to 2, and then a 95% is something close to 5. Again, you can do all the calculation on your own, but it sort of ends up with these values. So what are the problems? So here are some of the assumptions with the QPQS formula. Number one is that the arterial oxygenation and the pulmonary artery oxygenation are the same. For all intents and purposes, this is true because remember the single ventricle has all the blood, and then the blood in that ventricle goes either to the pulmonary or the arterial circulation. So it has to be the same saturation. The rest, however, this one up to this one, these are problematic. So the second assumption is that your pulmonary vein is near 100%, so it's 95 to 100%. The second assumption is that your oxygen extraction is only around 25 to 30%. And then lastly is that your mixed venous gas comes from the SVC. So what's the data? So in this study, they actually compared the pulmonary venous oxygen saturation based on the patient's FiO2. And again, the assumption for the QPQS formula is that your pulmonary venous oxygenation is always more than 95%. But as you can see, as you go lower in your FiO2, you have more desaturated values, such that at less than 30%, there's a significant amount of values which are less than your assumption of 95%. So what does that mean in practice? So I personally would just give these patients on 30 to 50% after their Norwood, because you just want to maximize their oxygen delivery, and I don't want to take the risk of finding out that these patients are actually having very desaturated pulmonary venous blood. What about the issue of oxygen extraction ratio? So as I said, we assume that it's 25%, but in reality, it can be as high as 50 to 60%, especially if they're going down the drain when they're in shock or elevated lactate levels. But they can be anywhere from 30 to 50% with very minimal clinical signs and symptoms. So that becomes a problem. And then the other issue of where your mixed venous blood is coming from. So the right atrium is typically 25%, but depending on where the tip of your catheter is, it can be 35% or 20% if it's in the inferior vena cava. So this is a classic example of why relying on the arterial oxygen saturation is probably not a good thing for this patient. So the top line is arterial oxygen saturation. You have your mean arterial pressure, and then you have your SVO2, which is a surrogate for your cardiac output. So as you can see, pretty much most of the time, the patient actually has very good arterial sat. The only time it sort of like reached 75% is at this point. But and then also at the same time, your blood pressure is actually pretty good. In fact, at that point where your sat is very low, is on the low side, then your arterial pressure is actually high. But again, what we want is oxygen delivery. So at this point where your sats are still okay, your mixed venous oxygen saturation is very low, such that your cardiac output is pretty much zero at this point. But again, at this point, sats are good at 75%, you have good arterial blood pressure. So relying on the sat is not a good way of managing these patients because of the inherent problems that I showed you earlier. So what about the effect of respiratory maneuvers? Preoperatively, we do a lot of manipulation of the pulmonary vasculature to try to improve QPQS and then hopefully improve cardiac output. But I'm going to tell you that after Norwood, manipulation of the pulmonary vascular resistance is sort of useless because the bulk of the resistance actually comes from the shunt, either from the modified BT shunt or from the Sano shunt, such that the most effective way of managing managing QPQS in this patient is actually playing with the systemic vascular resistance and sort of like disregarding the pulmonary vascular resistance. So how do we do that? So this is a diagram of how the phospholipase C pathway occurs. And this is important because your end product is your change in your SVR. So you have your alpha receptors, which is where your catecholamines work on. And you actually have another receptor for vasopressin. Again, the end product is an increase in calcium. If your calcium increases, then your SVR increases. There are some centers in the US where they maximize this equation, which I mentioned earlier. Again, if the blood pressure is the product of your cardiac output and your systemic vascular resistance, as I mentioned before, what you want is an increase in cardiac output, which is secondary to the an increase in blood pressure secondary to your cardiac output and not through your SVR. So if you knock down your SVR, then any increase in your blood pressure means an increase in your cardiac output. So how do they do that? So there's such a thing as a phenoxybenzamine, which is an alpha-1 blocker. So if you block that, then you block the whole system, and then you cannot increase your calcium. If you cannot increase your calcium, then what happens is a decrease in your SVR. Sometimes this becomes a problem that their blood pressure is so low that they actually cannot have adequate oxygen delivery. So the way to counteract that is to use vasopressin, which again works through the same pathway, but sort of like bypasses the alpha-1 receptor, which has already been blocked by phenoxybenzamine. So this is how we do it at Yale. So someone who's post-op Norwood would come up to us in the ICU, typically intubated with an atrial line. It's a combined atrial line because they don't have any more atrial septum. They have an arterial line. They have two chest tubes draining each chest, one mediastinal chest tube, and then pacer wires, and then polycatheter. These are typical settings that they come up with, or at least the initial management. So they come in intubated. Our goal is to keep them with normal acid-base balance, so 7.4 PCO2 and then PO2 And I tend to keep them with FiO2 30 to 40%. If we follow the blood gases closely, especially the base deficit. They may come up on dopamine, definitely with milrinone plus minus epinephrine. And again, our goal is adequate perfusion with the lowest acceptable blood pressure. We monitor lactate closely as often as every 6 hours. We keep them on 2/3 maintenance IV fluids. I think this is more institutional than anything else. We keep them very sedated with fentanyl. If we can't keep them sedated and they're still trying to breathe, then sometimes we paralyze them. And then we maintain the hematocrits in the 40s. So as I mentioned before, like around 6 to 12 hours after bypass, then they go into low cardiac output syndrome. So how do we manage it? First thing is we need to make sure that they're in sinus rhythm, because again, the component of atrial kick. If they're not in sinus rhythm, then we probably would pace them. We want to make sure that they're not bleeding. We keep their crits in the 40s, and then we keep the CDPs like around 8 to 10 cm water. If the cardiac output is still low, then we would tend to increase the dopamine to around 10, but that's the most that we're going to do, and then increase your epinephrine. We try to keep it at less than 0.1, but sometimes, you just need to bring it higher just to improve your cardiac output. And then at that stage, we would consider giving steroids or ECMO. We would tend to put them on ECMO rather than steroids because the use of steroids really has not been proven in this situation. So in summary, these are the goals of management for post-op Norwood patients. So number one is balance demand and supply, maintain cardiac inotropy, balance QP/QS, and again, as I've mentioned, if you do a good job with these three, then the last is really not an issue anymore. I want you to remember the figure on the right, and if you've maximized your cardiac output, then QP/QS is less of an issue. Because again, what you want is maximizing cardiac output and oxygen delivery. That's all I have. I'd be happy to answer any questions. Any questions? So I have I got a question. So what's the role of dobutamine? So the history of so let me put it this way. In the olden times when milrinone was not available, people would use dobutamine. And as you know, dobutamine increases, can also increase your inotropy and then decrease your SVR. I think in the absence of milrinone, that's a reasonable choice. But again, in the US, milrinone has been so common that we don't even bother using dobutamine. But again, also having said that, milrinone has been proven to decrease low cardiac output syndrome. As far as I know, there are no studies to show that dobutamine increases cardiac output in this setting. That's our preference for the use of milrinone. Second question: what is the choice of fluids on first post-op day? This is very institution dependent. So what we do at Yale is we, for these patients, because they're less than 5-10 kilos, we just put them on D5 water. And the reason why we do that is all our drips come up with normal saline. So milrinone, dopamine, all our transducers are in normal saline. So if we combine the D5 water plus all the normal saline, they're going to end up with something like quarter normal or half normal, which is what we tend to do for our patients. I know that there are some centers who use normal saline for these patients. There's no head-to-head comparison, or I don't even think there's any data to show that one fluid choice is better than the other. Role of diuretics in such patients. So in the first post-op night or even first post-op day, we don't give them diuretics because our issue is actually intravascular depletion more than anything else. Because remember, these kids go on bypass, they have very leaky capillary, so it's really hard to maintain the intravascular fluids. And in fact, we tend to give them fluid boluses during that first post-op night. After the first post-op day, when the hemodynamics are actually much better, then that's when we start them on diuretics. My preference is to put them on an infusion, like Lasix infusion, and that's because that avoids swings in blood pressure and swings in perfusion. There are some small studies that show that infusion is better than intermittent diuretics for cardiac patients. But again, it's really very attending preference. I have colleagues who would prefer putting them on intermittent Lasix rather than infusions. Calcium boluses or infusion, which is preferred to maintain calcium levels. So the thing is, these patients who have hypoplastic left heart or those who undergo Norwood do not usually have DiGeorge syndrome because DiGeorge is a completely different embryology. So they tend not to need a lot of calcium. So we tend just to give them calcium boluses. It's so unusual for them to receive infusion, at least in the first post-op night. Later on during the course, if they have a lot of calcium losses because of the Lasix infusion, then we may put them on calcium infusion, but that's so unusual. So the answer is we just give them calcium boluses. Why 2/3 maintenance fluid if we are worried about sears? So again, this is something very institutional, and I've had discussions with with my intensivist mentors and cardiologists and cardiac surgeons why you put them on 2/3 maintenance, and it's sort of like a it's sort of like a split personality. You know that they're gonna leak. You don't want them to leak a lot more, so you just put them on 2/3 maintenance, but also knowing at the same time that you're going to give them fluid boluses. I don't have any good rationale for putting them on 2/3 maintenance, aside from the fact that you try to minimize, fluid overload after the first 24 hours. There are some centers who would actually put them on full maintenance, and I think their outcome is just as good as putting them on 2/3 maintenance. I think the most important thing is, if you put them on 2/3 maintenance, is that their glucose are okay, because that may be an issue, and you keep a close eye on the intravascular volume status. And again, you may have to give fluid boluses here and there, but as long as you're keeping a close eye on these patients, you should be okay. So I think the issue is really more of the monitoring and understanding their physiology than the actual amount of fluids that you give them. Whether you give them 2/3 or full maintenance, you need to keep an eye on them. Any more questions? Okay. Any more questions? Okay, thank you very much. I think, that's all the questions that you have. In case you have additional questions, feel free to send me an email. I'm sending my email address right now. Okay, so just send me an email and then I'll answer you as soon as I can. Thank you very much.